Steve brings more than 25 years of experience leading digital healthcare transformation initiatives, beginning with early EHR adoption efforts in 1999. As a consultant, fractional CXO, and founder, he has raised more than 20 million in private funding while focusing on improving healthcare affordability and access. He's also a fellow of Belmont Collaborative for Health Systems Innovation at Thomas F. Frist Junior College of Medicine. Welcome, Steve. The stage is yours.
Thank you, sir. I appreciate it. Now, I'll be probably pretty quick just because I'm going to use the first two presentations and just say everything they said. We're going to say yes to all of that, and we think we're a big solution, a big part of the solution of all the what's broken conversation. But real quick, I am going to put in the chat my information if you want to take any of my email or LinkedIn, feel free. And then Daria, nice to see you. I know we just talked, I think, last week, so nice to talk to you again. But real quick. Again, my name is Steve Carbonara. 25 years in healthcare IT. I've basically sold, business developed, operated XYZ, whatever, around every technology that's touched a provider clinic. Don't have a tremendous amount of time spent in the hospitals, in the acute care side, just a little bit. But most any technology that was launched into a provider clinic, I had touched in some way over the last 25 years. So, the interesting thing was, I ended up leaving corporate about 8, 9 years into my career because I just didn't like what I was seeing from the business side. A lot of you might be on the provider side, and so you have a different take. But from my side of the vendor discussion, I didn't like seeing some of the corruption, collusion, all the bad words that I started really, and I'm just a very blunt guy, so I'll just say it very, very transparently. I started bitching and moaning about this stuff a long time ago. And about 15, 17, 18 years ago, I was throwing up flags saying none of this makes any sense. There's a lot of corruption. We have to really start looking at this. And what's interesting is all the things that, people around me and myself that we were talking about has now become common sense, right? And in the last 5 years, it's like, oh my God, this is so obvious to everybody. So what we're doing and kind of the translation to where we are today is people around me for the last 15 years have been thinking about a solution, and we couldn't figure out anything with tech that would be big enough to solve the problem, right? To solve what is wrong with healthcare. So what we decided was to just go all in and design a replacement to primary care. So we are creating the activated patient health MSO in clinics. It's TAP for short. So TAP Health has a national MSO. We, as an MSO, will build, launch, and operate one clinic in every state. The reason why is because we wanted to own and have our own team on the ground in every state in that regulatory environment. Within every state, obviously, as an MSO, we will have clients, other clinics that we look to provide services to. But the reason why we thought that this was only able to be developed this way and delivered this way was because we see a lot of things that are happening right now and the change that's needed it not being big enough, right? People who are trying to walk away from traditional medicine to go into direct primary care or holistic clinics or functional health clinics, whatever it is, it's really just creating more division for the patient, right? There's not enough structure around it. And no offense to the people doing it, a lot of people are just being very greedy. You're seeing compound pharmacies, putting products out into the market for $100. They're being sold for 800 a month or $800 per product, which is usually a monthly, prescription. So you're seeing just tremendous amount of waste and greed, just like you are in traditional medicine. We aim to solve a lot of that. We're looking to build this entire network of clinics and all the services offerings around it to benefit the patient, who is also the taxpayer, and to benefit the doctor. We're basically building a for us, by us model for the patient. But the big thing is, as I speak from the patient point of view all the time, because that's what I am, I understand that the only group of people that are ignored as much as patients in this country are the doctors. The standing that they've lost over the last decade with the PE consolidation has been tremendous. And so when you really look at it, we're probably the two only groups in, stakeholders in healthcare that matter. We pay for everything, we do everything, but we're the only two that aren't listened to at all. So we're trying to bring an effort around building a replacement opportunity for primary care that leads toward reform, that leads toward us having a collaborative of physicians and patients in a network that can work together at state level, at federal level, to start putting ourselves in a position to negotiate at the healthcare, table. And I think that's one of the biggest things that we're focused on. And a lot of people who hear what we're doing with building an MSO and clinic think that we're just trying to build another DPC, right? Because we're membership oriented, we're cash pay. So it just sounds like another thing that everyone just equates to already being done. We are putting together probably 10 different initiatives that are remarkably different than anything else in the market today. And so we are just getting launched. This process has been ongoing for Uli, he knows he's been on my team with Patients First Foundation for almost 2 years now. We evaluated hundreds of opportunities of how to drive impact for a good year in the last 18 to 24 months. And then since September, we decided to do this project. And this project has been funding. We've been raising money since January, and we are now coming to market right now with a funding partner that is backed by an $80 billion fund. So we are connected to some funding partners that have an idea for change at the scale that we have. So that's a pretty quick, just run through, very high level. I can answer questions. Usually it's easier that way because you're probably going to ask something very specific compared to where I can go.
Great. All right, I forgot one person in the audience, Dr. Susan Gunduz. She deserves an award because she probably attends every single Innovator MD meeting. So thank you, Susan, for joining us again.
Well,
Do you want to introduce yourself?
yeah, hi, I'm Susan. Goodness, first of all, I would never miss Uli's meetings. He has the best people on, and he really is just wonderful with his speakers. So I'm a pediatrician, and I'm building a platform using AI to identify developmental delay in early childhood and using AI to deliver intervention along with referring out for in-person care as well. So I'm working on that product. Thank you, Uli.
Yeah, thank you. Any questions? I see Bhargav, you have a question, your hand raised. Go ahead and ask Steve.
Hey, very, very nice to see you. And actually, my co-founder is in Pittsburgh. His name is TJ. So
Yes.
maybe we can talk at some point. So I'm interested to understand a little bit about how you see direct primary care and cash-based services integrating with the rest of the healthcare system. Because one of the main issues with DPC is that specialty connection. And to be honest, even with value-based care, that question of what happens when the patient gets referred to the hospital is still sort of unanswered on at least on a system level. So I'd be interested to know what you think about this.
Yeah, so I'm basically Mike Tyson in healthcare leadership. So I'm not looking to really work within anything. We're looking to bust things up. And I say that very, very directly because that is one of the issues with reform. We're all trying to stay within the box. We're all trying to stay within the guidelines that were created that have led to the failure that we are in today. I am the exact opposite. I don't believe that we should keep any of the existing systems if they don't prove out that they're worthy. So to a certain degree, that's what you're doing, right? I think what we have taken so long to get this thing launched is because we didn't want to do it the wrong way. So we've addressed almost every single issue you could ever think about because I've had nothing more than 50, 70, 80 people involved in dissecting what we should be building. So the answer is this: we are looking to partner with a coverage entity, a health plan that will allow us to white label and build our own offering. Um, we are debating about doing that because we can stand it up very quickly and have a coverage option for these patients that will solve the specialty and acute needs that they have. But my partner, Dr. Davis, actually in building his business back in the 2000s that he then sold to Mercy in St. Louis, Dr. Davis owned and operated a risk-bearing entity. So we are literally right now deciding whether we want to raise more money to build that business in parallel with the clinic. Our job is to go to the patient, provide them direct answers and solutions to the problems that they have, not say we'll help you get something figured out with the existing parties that have failed to deliver over the last 10, 20, 30 years. So that's the easiest way for me to say it. We are looking to work with the hospitals and the specialists, but only in a situation where we are equals and we are solving the problem for the patient. So we are going to be coming to the table with each one of those parties to negotiate those terms as we build that risk-bearing entity. That makes
And
sense.
that's really the problem with the risk-bearing entity without large presence has little negotiating power with the local health plans, which has been which was my issue as a private physician myself, because now it just come in and give you an 80% Medicare contract for FFS, and it's like you're paying me 20% less than Medicare. And I have no negotiating power as a primary care physician. Not as as a radiologist in my case, but as a primary as well.
Yeah, so we're looking at it from the point of view, and I'll just say this real quick: concierge medicine, cash pay, DPC, they're all the same to me. I don't look at any of them being different. It's all just marketing. So at the end of the day, it's all membership based. And so when we look at it, we're looking to solve the problem for the patient, which again, my policy wonks that I work with believe that there's about 100 million people in the country that are underinsured or non-insured. And so at that point, there's 100 million people for us to sell into, not having to worry about the people on Medicare, Medicaid. They can continue doing what they're doing. I'm not going to fight to have them join us. I'm not going to spend marketing dollars trying to convince them to come with us as well. If somebody on Medicare, Medicaid wanted to use our services, they're more than happy to. They can buy in just like any one of you. When you buy in, you get what you get. It's a membership. There's an a la carte pricing model to help you understand what it is that you may need or to buy or interact with. So at the end of the day, part of it is not trying to solve all the problems, right? Medicare, Medicaid, own thing. Employers, like I'll give you the example of, I talked to an employer the other day that was saying to me that we have our BUCA plan, and we're some big pharma company, and so 95% of the people in the business that are full time go with our plan. And it wasn't 95, but it was like 95% of the people that were open to it, meaning like there was other people in the company that they took their husband or wife's insurance from their other company. It was better pricing, whatever. Point being was from their point of view, it was like, we're great. Everybody that needs insurance from us gets it. Like, everything's solved. Well, then I'll never talk to that company. I have no desire to go talk to an employer to help solve a problem that doesn't exist in their eyes. So we're looking at the companies, like an employer I spoke with, 20,000 employees. Most of them are gig workers. 19,000 do not have any insurance. Of the 20,000 employees, only 1,000 of them chose the BUCA. And the CEO told me, he's like, it's not my fault. It's not my problem. I just can't think about it. I don't have time to care. Well, we care. That's what we're doing. We're thinking about those 19,000 people. And the thing that's so hard is that these employers are forced into all this like payment and engagement to monitor all this stuff, and they don't want to. So this 20,000 person employee, 20,000 person employer basically said to me was, I just don't want to do any of this. And I said, great, because all I want you to do is tell your 19,000 people to call me directly. So we are building a direct to consumer discussion. We don't want the employer involved. We want our care to be portable. You should be able to take it from employer to employer. We think that with the gig economy, there's just millions of people doing 2 or 3 jobs right now. They're doing Lyft, they're doing XYZ on the side, like, whatever it is. And that's what we're looking for, the employee or the, independent that needs a solution.
Great.
Thank
Thank
you.
you very much. Are there